Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to another episode of the Egg Whisperer Show. Doing this show is so special to me for so many reasons, but one of them is I get to connect with amazing, brilliant doctors all over the country and world, and a lot of them are my really close friends. So today, I'm super excited to have Dr. Jenna McCarthy. Hi, Jenna.
Hi, Amy. It's great to see you.
Nice to see you, too. Jenna and I have known each other for 15 years, but I could keep going on and on. But Jenna, why don't you tell our audience about yourself?
Sure. So I'm Jenna McCarthy. I'm a reproductive endocrinologist, and I work for a company called IVF MD, which is a medium-sized IVF practice in South Florida. We have 12 docs, and we have offices throughout South Florida, from Miami all the way to Vieira, and all the way out to the west coast of Florida in Naples. One of the things I love about our practice is that each of our offices is generally small with only a couple of docs. And so we maintain, even though we're a larger practice, we maintain that that small office feel where when you walk in the door, people know who you are and why you're there, and you don't end up feeling just like a number. So that's something that we take very seriously and pride ourselves in.
Awesome. And I want to read your bio because it's very impressive. So you went to Dartmouth for undergrad. That's one of my favorite universities in this country. She completed her medical training at University of Michigan, and that's where we know each other from. She's one of the top, and that is one of the top 5 women's health programs in the U.S., not to toot our own horns, by the way. And she's one of a handful of physicians selected by the American Board of OBGYN to complete her training as a combined 6-year residency fellowship. And that was a really big deal, and still is, that she was able to do that. And as a fellow, she was awarded grants from the Fibroid Foundation and the NIH for her work on uterine muscle stem cells. She's published numerous articles and co-authored multiple book chapters on her major research interests, including uterine fibroids, ovarian reserve, and fertility preservation. And she's presented at multiple national and international meetings. So the topic of today's show is how to avoid the most common IVF mistakes. Jenna, how long have you been doing IVF for? Tell our audience.
So if we exclude my fellowship training, I've been in practice for 10 years.
Yeah.
And as you can imagine, have seen a fair number of mistakes.
Yeah. So for 10 years, lots of mistakes. We want people to avoid these mistakes and also hear that they're common and they happen. So I just want to go through a whole bunch of them for our audience. I think it would be really helpful for them to hear from an expert like you. So here's one mistake: bending the needle. You have the needle, you're going into the vial. What would you tell a patient?
Oh, definitely. So this is something that can happen pretty easily because those needles are pretty flimsy. And usually what I tell people is, with any of these IVF mistakes, particularly when you're dealing with medications, first off, don't panic. If it's something that you can correct easily at home, go ahead and do it. If not, call your practice, call your team. They're there to help you. In this particular situation, just set the vial down and see if you can extract the needle from the vial. If it's not coming out easily, you can even disconnect it from the syringe, which I would probably do if you have a fair amount of medication in the syringe already. But just slide it out, put on a new needle, and start over.
Exactly. Don't Google it. Don't YouTube it. Call Dr. McCarthy. Exactly. So what about patients who run out of needles? You think you have the right needle, and then all of a sudden you're out of your 27 gauge half-inch. What would you advise a patient?
So fortunately, a lot of times pharmacies will have needles that you can get. So by contacting your team, they can call in a prescription to a local pharmacy for you. The other thing to keep in mind is a lot of times we have these needles at the office. And so it's not uncommon for me or one of my nurses to run back to the office to meet a patient and provide them with something like that so that they can continue on.
And worst case scenario, if it's 10 o'clock at night and that's just not an option, you can always take an old needle that you used and, believe it or not, wipe it with an alcohol swab. It was in your skin, it's not contaminated, and put it back in. That's also okay, and something that I've told my patients to do. What if you have a needle but it's not the right size? Like you have the 22 gauge 1.5 inch for mixing, but you don't have the 27 gauge. What would you tell a patient?
You can always use needles interchangeably. We pick the needles that we pick because they tend to be the most comfortable, but that doesn't mean that you can't use a larger needle, a longer needle, or a thicker needle to inject the medication. It just tends to be a little bit more uncomfortable.
Yeah, and don't put the needle all the way in, and call your doctor when that happens so we can advise you. The only dumb question is the one that you didn't ask, right?
Absolutely.
Yeah. And then what about if you've run out of a medication? Like you have enough Menopur, but you're out of your Gonal-F.
That's definitely something where you're going to want to talk with your team, because some medications, not all, are interchangeable to a certain degree. And so we may be able to help you out with medication you already have at home, or we may, again, meet you at the office because we may have some samples that we can provide you. And then finally, a lot of practices have sort of an emergency pharmacy in their back pocket. So we have one of our local pharmacies does keep a little bit of medication available. It's unfortunately more expensive, but if it's just one night kind of thing, it's better than losing the whole cycle.
Yeah. And then another thing along the lines of a vial, we talked about bending the needle, but what if you put your needle inside the vial and you keep pulling air out? I'm sure you've gotten that call at 10 o'clock at night. All I'm getting is air. I see the liquid and the liquid's not coming in. What would you tell the patient?
So that happens a lot. One of the most common reasons for this, there are two, but one of them is simply that the needle is above the level of the fluid. So you need to gently pull the needle back till it's underneath the level of the fluid. So it's in the fluid. That's going to help draw it up. But the other thing that can happen is either you don't have a full seal between the needle and the syringe, or you have a small crack in your syringe. And so another option is to simply put the vial back down and start over with a new needle and a new syringe.
Yeah. And how often do you see it where a patient comes in for her retrieval and she has a sip of water? Is that a common mistake that you guys get?
Not too much, because we really do stress with patients not eating or drinking, but it has happened. And it's not the end of the world. A sip of water, we can usually still proceed with conscious sedation. If you forgot and you had a full breakfast, and that has happened, then the procedure is going to have to be done without conscious sedation, but it can be done. And in the rare instances this happened, patients come in completely freaked out, tearful, understandably. They think that they've lost their whole cycle. And there are things that we can do. Absolutely. And so don't just not show up. Don't ghost your practice. Call them, tell them what happened, and let's see what we can do to kind of make this work for you. We're as invested in your cycle as you are.
Right. Exactly. We take it very personally. We want patients to succeed. And what do you tell the partners, either a male partner or a female partner, as to what to eat or drink that morning? Because sometimes they think the instructions are for them too, and they shouldn't eat or drink also.
Yeah, no, we want them to have breakfast. We want them to have their cup of coffee, because we don't want them passing out when their wife's IV is put in. And so we usually encourage them to go ahead and eat and drink normally.
Yeah. So do you have any common mistakes that you've heard or seen regarding the trigger shot and the timing about that?
Yeah, the most common mistake is forgetting to take your trigger shot at exactly the time that it was supposed to be taken. This is something that practices do stress when you're doing your IVF consult or your injection class, depending on how your practice does it. But sometimes life gets in the way, or I'll get a frantic call from a patient. Their trigger was supposed to be at 7:30. They left work with what they thought was plenty of time to get home, and now they're stuck in Miami traffic, and they can't get home, and they don't know what to do. If you call your practice, we can move things around. And so things that we've done, for example, I've said, okay, don't take your trigger at the time we told you, because you're going to get home too late. We're going to move your retrieval to the end of the number of retrievals that we have for the day. Or they don't have their trigger shot, and so we have to run out and get a trigger shot for them. And so then we're going to be moving the time of their retrieval. So there are definitely things we can do, and that's why talking with your practice is so important.
Exactly. So, for example, you think there might be a long drive home, perhaps bring your trigger shot to work with you that day. That's one thing. And the other thing is, we as doctors don't want to find out on the egg retrieval morning that you're 2 hours off with your trigger shot, right? I mean, we'll always be there to help you for sure. And then what about the semen collection, or the sperm collection? What kind of mistakes have you seen associated with that?
We've been lucky. Our guys have been pretty good, but occasionally we'll have, sometimes it's just nerves and they're not able to collect on the day of. That's probably the most common. And I definitely want the guys to know that happens. And they, please don't feel like you're the only one that this has happened to. More commonly, guys have ejaculated too recently. They didn't realize that they were supposed to be abstaining for a certain amount of time. We typically ask our our partners to ejaculate on the day of trigger, so that we can kind of have as fresh of a sample as possible. And then in the message that they get, there is a reminder, like, please don't, again, prior to the retrieval. But sometimes that happens. That's the big one. We've been fortunate. We haven't had a situation where a husband didn't realize that he was supposed to be there at all. Although I could envision that happening, particularly if you have husbands who are out of town or out of the country.
Yeah, I had it happen once. He was out of state. And I was like, huh? Whose sperm were we supposed to get? Seriously. And it wasn't frozen ahead of time. I was like, anyways, it all worked out. He was in a local state like Colorado, for example. And then he just flew back same day and we got it right in time. But that just makes me reinforce things a little bit more forcefully with my patients, that the retrieval time is the semen collection time. We need you there. If you're not planning on being here, we'll freeze a sample ahead of time. If you think there's going to be a sperm emergency, we're going to freeze a sample ahead of time as well. Okay. Have you ever had patients use the wrong medication? So for example, they gave themselves the trigger shot instead of the HGH, or the Ganirelix instead of the trigger shot?
I have. The most common mistake that I've had, and it's happened a few times, unfortunately, is as we're adjusting estrogen doses during a frozen transfer cycle, patients accidentally take their vaginal progesterone orally. It doesn't harm them, but unfortunately, when the lining of the uterus is exposed to progesterone when it's not supposed to be, it ruins the whole cycle. And so for those patients, we stop and we have to start the cycle over again. Fortunately, in these situations, right, the embryo is frozen, and so it doesn't care. It just thinks that the transfer was next month. Emotionally, it's difficult for the woman, but certainly better than going through an unsuccessful cycle.
So when you said, sorry, keep going. No, this is.
I was going to say
this is good.
Fewer errors on the fresh cycle, and I think it's because we speak with patients. We see them daily or every other day as they're going through their cycle. So any questions that come up, they ask us. We've had patients bring in medications and say, "Is this the one I'm supposed to take?" And so we've had fewer of those problems.
So I just want to go back to you saying she took the vaginal progesterone orally. Are you talking about the endometrium?
No, we use micronized vaginal progesterone, like Prometrium. Right. No.
That's a big tablet. I actually had a patient place it rectally because she read it online and thought that she could do that. And I'm like, whoever wrote that online hates people. And they're just like messing with you because you don't put vaginal progesterone rectally.
No, that would not be comfortable.
No. Okay. What about, another story. I actually had a patient take birth control pills during her frozen embryo transfer cycle because she wanted to keep having sex and not get pregnant.
Oh no.
So please tell us. And she told me it was actually at the time of the embryo transfer where she told me this. So I was literally about to put an embryo in and she's like, "Oh, I'm going to stop taking the birth control pill now." I'm like, what?
Oh,
so
no.
I'm just so glad we caught it because obviously the transfer probably wouldn't have worked, but it's just so important to just talk to us. Tell us what you're doing. Tell us what you've done. There's a reason why we've given you instructions. And the other thing, I don't know if you've noticed, is sometimes you give patients an instruction for something, but the pharmacy will put different instructions on the bottle.
Mm-hmm.
Have you seen that?
Yeah, they'll say, don't take estrogen or progesterone if you're trying to get pregnant. And if they talk with the pharmacist, sometimes the pharmacists double down on this and say, "Oh no, this is going to cause birth defects." And we have very concerned patients calling us, and we just have to reassure them. Listen, unfortunately, in this particular situation, the pharmacist is giving you, bad advice. Estrogen and progesterone are normal pregnancy-related hormones. If you take them at the wrong time in your cycle, they're a contraceptive, but it is safe. We wouldn't prescribe something that's not safe for women to take during pregnancy.
Exactly. And then what about taking expired medications? I mean, in a lot of other areas of medicine, sometimes it could be okay. What about infertility medicine?
I recommend against it. I mean, these cycles cost anywhere from $10,000 to $20,000, depending on what type of cycle you're doing and what type of add-ons you have chosen for your cycle, genetic testing, HGH, that sort of thing. Why would you want to risk it to save a little bit of money on the medications? You want to make sure that this cycle has the greatest chance of being successful. And so for me, that means using meds that aren't expired.
Yeah. And then tell us a little bit about your practice, where the lab is, where all the clinics are for the doctors, because I imagine you guys have to do a really good job telling patients where to show up for the egg retrieval.
So for the Jupiter practice, it's not too difficult because we operate basically as a small boutique clinic. We have 2 docs and we have our own lab in-house. The compromise that we make is we do batching. So we're only doing IVF for 2 weeks out of each month, and the remaining time our patients are, having to synchronize their cycles using birth control pills or luteal estrogen or something like that. We do have our main office is in South Miami, and that's our largest lab. So patients who can't wait until our batch. So for example, our cancer patients who are doing fertility preservation where every day is a delay in the start of their chemo, or patients who have severely decreased ovarian reserve and we're trying to do a start without any form of hormonal manipulation ahead of time. Sometimes those patients will have to go down to our South Miami office. And so we have to be really careful to give them good instructions. We talk with them about, what Miami traffic looks like compared to Jupiter traffic, because it's like the difference between, traffic in Denver and traffic in San Francisco. And we think we know traffic till we drive south. And then we also offer them the option of maybe staying in a hotel down there, because that relieves a lot of stress. They can do a drive-by, make sure they know where the office is the night before, and then stay in a hotel, get a good night's sleep, know that they're going to be able to get that. I mean, literally the hotel that we recommend, they could walk there if they needed to, instead of driving. And it takes a lot of the stress off, because we don't want someone showing up at the wrong office and then having to reroute and go to Miami. That would not be good.
Yeah, I mean, I had someone show up for an embryo transfer once in San Francisco at a lab, and I'm like, that's not even my lab. Like, why did you go there? But the written instructions, believe me, were very, very clear. And it wasn't a big deal. I mean, it just took a little bit longer, and I just had to rearrange my schedule. But that's why looking at the instructions, looking at the address, asking those questions ahead of time is so important. So you're not like in a panic. But we can always deal with whatever patients end up doing or going for the most part. How about if you're a patient and you don't get a follow-up call on your blood work? You know what I mean? Like, you're doing IVF, you're going in for your monitoring ultrasound. What kind of steps does your clinic take to prevent that mistake of, a patient not knowing what she's going to do that night?
Unfortunately, that can happen, right? We're all human. And even though our nurses and doctors are trying to do everything perfectly, mistakes can happen. So there's a couple things. First of all, is every patient who goes through an IVF or some type of a stimulation cycle with us has a personalized voicemail that's set up within our system, a private voicemail with a password. And so we leave messages there. That way there's less concern of, could you have potentially misdialed a phone number and left a voicemail on the wrong person's voicemail? Could you, you spoke with the patient, but when you call a patient, you don't necessarily know where she is or what she's doing at the time. Maybe she's at the gas pump. Maybe she's staying in front of her boss and she doesn't want to say anything that would reveal what she's doing, but can't really tell you that either. And so this private voicemail has been really helpful because patients can call in at times that are convenient for them. And then we always have someone on call. We have a nurse on call till midnight, and we have doctors on call 24/7. So if someone doesn't get a message on their voicemail, they can simply call, and the on-call doctor or nurse will look in their chart and say, oh, I see you were supposed to take this much medication tonight and come back tomorrow, or whatever the current protocol is going to be.
Yeah, perfect. No, that sounds great. So 2 other mistakes that I've seen before, and one of them is a trigger failure, where you've told a patient to take a trigger shot and she actually didn't take it, and you kind of find out the hard way. Have you ever had that happen before?
I've had trigger failures, but never because the patient didn't take the shot. I've had, unfortunately, that situation where the post-trigger labs looked really good. And when we went in to do the retrieval, we weren't able to get any eggs out. In situations like that, what we've done, obviously after discussion with the patient, is we've tried retriggering using a different type of trigger to see how things go. We also offer the patients, the option of simply canceling the cycle and starting over. But certainly if you have a patient who knows she didn't take her trigger and she tells you that morning, or if the labs reveal that she thought she drew up her HCG, but she really drew up the water and didn't actually mix it with the powder or something like that, sometimes we can kind of look at the rest of the hormones, and there's an old-fashioned process called coasting, where women actually go a day without hormones to kind of let their estrogen levels drop prior to trigger. And that used to be done when we were seeing a lot of ovarian hyperstimulation syndrome. And so it may not be the end of their cycle. And so again, that's a situation where you're going to want to talk with your doctor and your nurse about what can be done potentially to remedy and salvage the cycle.
Perfect. So I think one of the biggest mistakes when it comes to IVF is not having the right set of expectations going in. This process is taxing on our hearts and our souls financially it's taxing. And I think that's the biggest risk, is of the emotional toll that this whole process takes. And not having the right set of expectations is part of that. So if you go in with the right set, then no matter what happens, you're prepared for it. And what do you do for your patients to prepare them for their IVF cycle so that they know what the expectations should be for success?
I mean, I think that's a great point. And it's, when we do, so all of my patients sit down with me before, getting ready to start an IVF cycle, and they do what we call an IVF chat. And basically what that is, to some degree, it's going through the risks and benefits of IVF. I mean, that's the official purpose of it. But I also think that it's to set expectations, because like you were talking about, someone could have what as a physician, I think is a very successful cycle. But if I don't tell her that I'm only expecting to get 4 or 5 eggs from her cycle, when she gets 4 or 5 eggs and she's read online that someone else got 20, she's going to feel very disappointed, like the cycle didn't go well. So one of the very first risks that we talk about when we're talking about risks of IVF is the idea that it might not work. And then I talk with them individually about what I think their cycle is going to look like. So I'll say to them, your antral follicle count is 5, which means if this is an ideal cycle, I'm going to get, for example, 4 to 5 eggs. And then we talk a little bit about what the average fertilization rate is with both IVF, conventional insemination, and with ICSI. And then we talk about what the blastulation rate is in our lab, so that they can kind of have an idea of, okay, if I get 5 eggs or if I get 15 eggs, about how many embryos do I anticipate you're going to have to freeze or biopsy? And I think that makes a big difference because, nationally, we're looking at about only 1 out of every 3 mature eggs is going to make a blastocyst. So if you have someone who starts at their cycle with 15 eggs and ends up with 5 blastocysts, I'm doing my happy dance, right? This is awesome. And she might be disappointed because she was thinking that she was going to have 15 embryos. And that's such a disconnect that we need to make sure that this doesn't happen, and that they're just as happy about the way the cycle went as we are, so that they realize this is a good thing.
Right. And I wish more doctors did that, because I'm sure you, just like me, get so many second, third opinion consults, and patients are hearing this information for the first time. But now, if you're watching this show or listening to it, you know what questions to ask ahead of time. Ask your doctor, what do you expect from my cycle? What would be considered a great cycle for me? And how many cycles should I consider doing for the goals that I have for myself? Don't you think?
Yeah, absolutely. Because there are some women who do need to kind of come in with the mindset of, I'm going to do a couple of cycles. And there are other women where it's very reasonable to anticipate that they'll be able to achieve what they're looking for in terms of the size of their family with a single cycle.
Yeah. So Jenna, thank you so much for being on our show. Thank you for answering all these questions about common IVF mistakes. I just want you to know, I went to your website and I saw this beautiful quote, and the quote was, hold the vision, trust the process. Can you tell us what that means for you?
Well, so I love that quote. Basically what it means is, there's a lot of detours and road bumps and potholes as you're going through the whole IVF process. But if you really keep your eye on what you're looking to get out of this, which is a healthy baby, that the process can be okay. And, you just kind of need to reach out to the people who are there to support you. And that includes your team. That's what we're here for. And just hold on to that final end goal that you're looking for, and you'll be successful.
I love it. And I wanted to ask you, because you have so much passion about what you do, and you're obviously so smart and so brilliant. What made you go into medicine, and more specifically fertility medicine?
I couldn't think of anything else that I would rather be doing than getting up every morning and helping someone to have a baby. I mean, honestly, Amy, can you think of anything that's better?
Absolutely nothing. Patients
job.
ask me all the time, when are you going to go on a vacation? I'm like, I'm sorry, why do I need one? I'm doing what I love every single day.
Yeah, it's pretty awesome. I mean, these women trust us with so much. It's really just, kind of a privilege to do it. I know it sounds trite to say that, but it's pretty awesome.
It is. So tell us again, where can patients find you? Tell us your website, all that good stuff.
Sure. So my office is in Jupiter, Florida, and our website is ivfmd.com. There are 2 IVFMDs, so please be careful. There's one in Texas. That's not us. We're the one in Florida. And again, my name is Jenna McCarthy.
Yay. Okay. Well, Jenna, thank you for joining us today. Thank you for your time. I hope everyone has learned a lot from this show. I sure have. Every time I talk to you, I feel like I learn more. So thank you for everything. And for those of you who are listening and watching, please be sure to tune into our next show. Hit subscribe on my YouTube channel and join my next Egg Whisperer class. I have the Tushy class right now and the IVF class. So go to eggwhispererschool.com. Thank you, everyone. Bye, Jenna.
Bye, Amy. It was great to see you.
See you soon.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.